thank you once again. And I understand catheters are a problem, and this catheter talk is between lunchtime. And I'm not going to hold you too much for your lunch session. So catheter tip design, where are we? We do know that catheters, we have to live with these catheters, and with all the technological advances in the different types of catheters that are available in the market, is any one type better than the other? Again, I have no disclosures. So what I'm going to talk about in my outline of my talk is going to be discuss catheter designs, discuss the role of tip design in catheter performance, and show the evidence from in vitro and clinical studies if they match up. So most double lumen catheters, as far as the body of the catheter is concerned, is essentially double lumen, and it has a Dacron cuff that helps anchor the catheter in the subcutaneous tunnel. And most of the differences are in the catheter tip. And when we talk of catheter tip, there are three main types: the step tip, the split tip, and the symmetric tip. And on each of these, on the tips, there are different kinds of holes or side holes. They may be present or absent. The side holes may be of different shapes and numbers, so they may be single or multiple, and they may be round, oval, or even rhomboid shape. And if we talk about specifics on the step tip catheter, the distance between the arterial end of the catheter and the venous end of the catheter, the distance can vary depending on what kind of catheter is being used. And similarly, in a split tip catheter, the length of the split, the distance between the split, and the shape between the two split ends of the catheter can be different. And again, some of the catheters also have flow dividers. So there are a lot of differences in the tip on various kinds of catheters that are available in the market, making it difficult to really identify and use a catheter that has the best performance, which is the ultimate goal. Here's a schematic of so the catheter A is the first double lumen catheter that was introduced in the market, which is the Quinton catheter, which essentially was a catheter with two oval lumens, and it was a step tip catheter, and step tip because it's like a step. This was redesigned by Mukherjee and changed into a double D lumen catheter with again a step tip. C is two separate catheters, each with a different kind of tip with multiple side holes at the tip. That's the Tessio catheter, which is not very often used these days, mainly in North America, but it's still being used quite a bit in Europe. D is the split tip catheter, and again the split tip can be of, as mentioned, can be of different lengths. It can be of different shapes. So this is a straight split tip, and F is the most recent one, which is a pre-curved tips that are split, and the reason being pre-curved is it's supposed to help self-center the catheter in the mid-right atrium. And the last variety, the E, is the catheter tip, which has a symmetric tip, so both the venous lumen as well as the arterial lumen open up at the same length. Going further deeper into the step tip catheter, as I mentioned, the distance between the venous limb, the venous opening, and the arterial opening, that distance can vary with the different kinds of catheters, and that is called as the arteriovenous offset. And it's believed that the distance can make a difference as far as recirculation is concerned. So the catheter AV offset distance can be anywhere from 20 millimeters to 30 millimeters. And some of these step tip catheters have flow barriers. So the flow barriers can be like a thin vertical barrier or a thick horizontal flow barrier, which again is believed to help with recirculation rate when these catheters are used in clinical settings. And on the split tip catheters, as I mentioned, it's the length of the split, how far the split can go, and whether the distance between the two split tip catheters is fixed or narrow. So here's the first two generations of split tip catheters with variations in the extent of split, 45 millimeters and 80 millimeters. The self-centric curved split tip catheters which has a wide distance between the two split ends, and this is a straight split catheter with a wide distance between the two splits, and the venous tip has a little bulbous end which is supposed to hold it in a straight position. And on the side holes, they can be either rhomboid shaped, multiple, single, oval, or round. So a lot of variations as far as manufacturing is concerned, and with these variations, the question to be asked is, does this really make a difference when it comes to dialyzing patients? Does it really make a difference as far as reducing the recirculation? Does it make a difference as far as catheter dysfunction from sheath formations? And to evaluate that, it's not an easy question to answer. I mean, first of all, how do we define catheter performance? So currently, as based on KDOQI guidelines, we need to have a minimum blood flow of 300 mLs per minute for the catheter to provide adequate dialysis, and with a recirculation rate of less than 10%. Now, the key factor, though, when we talk about catheter selection is the cost. How effective is the cost, and how expensive is the catheter? And again, in clinical practice, very often the catheters do get connected in a reverse configuration, by which I mean the arterial lumen is used for venous return and the venous lumen is used for blood pull. So when the catheter is used in a reverse configuration, is that catheter good enough to provide adequate dialysis, meaning a blood flow of more than 300 and a recirculation rate of less than 10%? Now, for catheter performance, it's not just the tip design that is important. There are other factors, patient factors and the operator factors, that are equally important. So just evaluating the tip design may not give us the correct answer to this question. Now, tip design definitely can affect the flow. It can definitely affect the recirculation rate, whether it's in a straight connection or in a reverse connection, and whether it leads to higher incidence of clot formation. But when it comes to tip placement, the important thing is, where is the tip placed? Is the tip placed in the superior vena cava? Is the tip placed in the atrium, whether it is in the mid-atrium or in the lower part of the atrium? And again, whether it is from the right side or is it from the left side? And more recently, there has been some mention about right atrial morphology and catheter tip placement, and people have described the right atrium shape, and this is what has been described based on the images that we see when we inject contrast as long tubular, small globular, complex, normal, triangular, and large atrium. In my experience, yes, you do see all of these kind of variations, but from practical standpoint, if the catheter tip is really placed in the mid-right atrium, most of these catheters will work. Occasionally we do come across a situation where even after placing the catheter in the right position, a certain type of catheter may not work, but a certain type of a catheter tip may work better. So again, that's not a common situation. More often than not, placing the catheter tip in the mid-right atrium would generally work the best. One should also remember that there is a potential for tip retraction. When the patient is in supine position, even after doing the procedure under fluoroscopy, the catheter tip may be in the right atrium, but when the patient sits up, the catheter tip tends to migrate, and they can migrate as much as 2 intercostal space, so the tip that was placed in a supine position in the mid-right atrium, when the patient sits up, is now in the superior vena cava, and that can lead to inadequate blood flow during dialysis. And more often, this problem is seen in patients who are obese, where the catheter is anchored to the pectoral fat, or in patients with large pendulous breasts. Again, right-sided catheters versus left-sided catheters, there is a big difference. The right-sided catheter has a smooth curve, and that's the preferred site. So if the catheter is placed in the left internal jugular vein, it tends to have multiple curves. It not only has a curve in the from the IJ to subclavian, from subclavian to brachiocephalic vein, but it also has an anteroposterior curve, which is not often appreciated with the two-dimensional chest X-ray. But when you see the catheter curves on a catheter that has been removed, you can see that it's not just in one plane, it's in two different planes. So you have multiple curves, which leads to loss of the laminar flow that you would normally see on the right-sided catheter. So having the preferred site to place a catheter is in the right internal jugular vein. So having gone over the reasons why a catheter performance may be poor, it's not just dependent on the tip or the catheter design, but it also dependent on various patient factors. That to understand some of the factors from the tip design, recently there was a nice article that created a simulation model and looked at whether the tip design makes a difference as far as catheter performance. So in this simulation model, they created a chamber which simulated superior vena cava, in which the catheter was suspended and fluid was pumped in to both the arterial and venous side of the lumen, as well as fluid was pumped in separately into the superior vena cava to mimic the superior vena cava blood flow. And using this model, they evaluated 9 catheters, 3 with step tip design, 4 with split tip design, and 2 with symmetric tip design. And each catheter was tested for recirculation rate, both in the standard and reverse configuration, and for the tip movement. So when the catheter was switched from standard configuration to reverse configuration, did that make a difference in how the tip moved inside the right atrium? Did it go closer to the vessel wall or to the atrial wall, making it difficult for the catheter to provide adequate blood flow? Now, these are the problems when we look at just the simulation models. One, the catheter tip was placed in SVC and not in the right atrium. So the simulation model to begin with had a flaw. And again, they also controlled for viscosity, and the viscosity they controlled for was 40% hematocrit. Again, how many of our dialysis patients have a hematocrit of 40%? So that's clearly not an ideal situation. And they looked at the data at 425 ml per minute. Again, most of our dialysis catheters are generally between 350 to 400, rarely over 400 ml. So their baseline characteristics were definitely not identical to what we see in clinical practice. But nevertheless, it did give us some information, and here's what they found. They also injected some blue dye to look for, and I hope it works, yeah. They injected blue dye to see how the blood flow and the catheter tip moved, and here the split tip catheter was, when they ran the fluid at 450 ml, the flow was way away from the arterial tip, and the recirculation rate was was less than 10%. Similarly, when they connected the split tip catheter in a reverse direction, now as you can see, when it is connected in a reverse direction, the venous end is being used as arterial pull, there is a high chance of increasing the recirculation. As opposed to that, the symmetric tip in reversed or in standard connection did not interfere with the recirculation, because as you can see, the dye is way away from where the venous and the arterial channels are even after they are reversed. And in a self-centric split tip catheter, when the catheter connections was reversed, so the blood was being pulled through the venous end, again you can see that the risk of recirculation is very high. So having evaluated 9 catheters, 425 ml blood flow, which again to point out was not an ideal clinical situation, the recirculation rate was insignificant with standard connections with all catheters. So that's one good thing. So as long as your catheters are connected the way they're supposed to be, so you pull from the red side and push back from the blue side, the recirculation rate with most of the current catheters available in the market is less than 10%. It was almost 0% in most of these catheters. But in reversed connection, the step tip had a recirculation rate of anywhere from 9 to 16%. In split tip catheters, it was 22 to 40%. With symmetric tip, it was 0%. And I could not get the film for the last statement that I have here, that stagnation of blood between split tips with reverse connection clearly showed that the risk of thrombosis in a reversed connection with split tip catheters was really high, because the dye tended to stay stagnant between the two split tips. Now, with this in the background, that the in vitro study clearly shows that some of the tip, there is excessive tip movement with reverse connection with some of the catheters, and some of the catheter tip designs clearly have a better recirculation rate. Does this really hold true when we look at in clinical situation? The problem with looking at this in the clinical situation is it's difficult to interpret. Most of these are single center studies. Secondly, the catheter types that are studied at different blood flow levels, so you cannot compare one study to the other. There is really lack of standardization to draw any meaningful conclusions. This is an example of how the clinical studies can have results all over, but yet we cannot make any definitive conclusions. There are 2 clinical studies with curved split tip catheters which clearly show that the outcome at 26 weeks is survival of the catheter and recirculation is better. 2 studies with symmetric tip, which is C and D, the yellow line and the blue line. They are lower than the curved split tip catheters, and again catheters, some of the studies have combined step and split tip in right IJ and left IJ. They have the worst overall outcome. There's one randomized multi-center trial, which was a prospective study done in about 600 patients from 15 centers, and they compared split tip catheter with the symmetric tip catheters, and these were all new catheters. So in most of the other clinical trials, the patients that were enrolled into the studies were not necessarily new patients. The patients even who had catheter exchanges were also included. So it was really very difficult to draw conclusions. In this study, of the 600 patients, roughly 200 patients had their recirculation rate measured at 3 different blood flows, 350, 400, and 450. At 1 week after the catheter placement, 5 weeks after the catheter placement, and in 11 weeks after the catheter placement. So this was much more of a realistic situation. And in this study, there was hardly any difference between recirculation rate, whether it was a split tip catheter or a symmetric tip catheter. The only difference was the venous and arterial pressures were higher compared to the symmetric tip in the split tip catheter, but again, they were not statistically significant. So the clinical evidence is completely against, or not against, but paradoxical compared to what was found in the simulation model. So, with this information, the way I look at it is, yes, catheter tip design can affect flow dynamics, but clinical relevance really remains unclear. In vitro results are not necessarily aligned with in vivo results, and catheter tip design alone cannot explain flow dynamics. Patient factors do play an important role, and in my personal opinion, I think it's the cost factor that should be a major consideration when you select a catheter. And number two, what are you comfortable putting the catheter in? Which catheter design you're comfortable placing in the patient is another important thing. So operators' skill as well as the cost are two major things, that major characteristics that I would consider when selecting a catheter. Thank you very much for your attention.
Thank you, Dr. Tushar. Okay, I may be asking a bit of very naive question, sort of a thing you can say. You've seen so many different designs over last 2 or 3 decades, different in vitro, in vivo studies. If we extrapolate or take a corollary, like patients who are on CAPD, if they have good ultrafiltrate, physicians are happy, patient is happy, we don't bother about any other damn test. Similarly, in the catheter tip, what do you think will be one point? Say if he's getting 400 plus ml per minute, the flow rate, yes, it's good enough. It is not going to get thrombosed. The tip is good enough. No need to go ahead with the so many other investigative things.
As you rightly pointed out, I mean, it doesn't matter which tip design is being used, as long as it is placed properly, and as long as it does not lead to infection and thrombosis and dysfunction. So proper catheter care and proper catheter placement skills are more important, I think, than the catheter design itself.
Dr. Tushar, although this is not part of your lecture, one very important thing is, does the material of construction of the central catheters and the fact that now they are launching heparin coated catheters, silver iron, does it really make any difference to catheter life? Because the cost of all the other standard catheters are more or less similar to each other. But whenever you go into, they talk about different construction material or coated catheters, the cost doubles or triples.
Coated catheters really have not shown to be of any additional advantage in the dialysis patients. Coatings, there are several different kinds of coatings. Coating only in the external area, coatings in the luminal area, coatings with antibiotics, coatings with antiseptics. All of these coatings have shown to be of some benefit when it's short term. So catheters, coated catheters used in the ICU setting have shown to be of some benefit. But as far as in the dialysis population, the studies that have been done have not shown to be of any benefit. So I personally don't use any coated catheters. They have no additional advantage, and no additional advantage even as far as thrombosis or reducing the rate of thrombosis is concerned.
So ladies and gentlemen, I think sir has told multiple catheter designs and tip designs, and there is a lot of choice, but as far as speaker is concerned, on catheter tips, Dr. Tushar is obviously the right choice. Thank you for those wonderful tips on catheter tips. The take home message probably is use with catheter whatever you are comfortable with. I think that should be the thing. So now I would like to open the questions from the floor on this topic.
I really enjoyed your talk. I'm Rakesh Mahajan, vascular surgeon. one little thing I wanted to ask, how do you assess when you put in a catheter that flow is adequate?
One, first of all, when the catheter is placed, you make sure that there are no kinks, and the catheter tip is in the right atrium. And after that, what I do is I connect a 10 cc syringe, and I pull as forcefully as possible to see if the flow is free without any stuttering. And it should be tried on both sides, both the lumens, and if you get a good flow, that generally should provide 350 to 400 blood flow when the patient is hooked up to dialysis machine.
I personally use 20 cc syringe, but I'm sure you also have would have encountered cases where in vitro, I would consider that as in vitro, but in vivo would be when patient goes on the dialysis machine. Have there been hiccups in the flow?
Generally not, but if it happens, yes, what I would think of is then tip retraction as a possibility. I would think of, I mean, sometimes we do not have a real explanation, and just using a different type of catheter in those situations has sometimes served the purpose, but sometimes we don't have an answer as to why.
But then do you have to reposition the catheter, or?
Yes, so you can try pushing the catheter in further and keeping it lower into the right atrium rather than in the SVC atrial junction or mid-atrium junction.
Just on a lighter note, I have added prayers as well as the last thing.
Yes, that's the last thing you can do.
Nice to hear your talk, sir. I am Dr. Ravi Jangmani from Manipal Hospital, Bangalore. So I felt out of all these different types of tips, the symmetric tape, it is easy to handle, and as most of the time we will not be able to assess it's a tubular atria or globular atria, those kind of things. And one of the important things in peripheral, when we put the perm cats and they are not in a tertiary care setup and they are going back to their native primary dialysis unit, sometimes once they feel the flow in arterial side is not good enough, they automatically change it without knowing the how it will lead to inadequate dialysis and the consequences. With this symmetric tape, even though they change, we think it is not going to give much of recirculation, and even with that also we will have a good dialysis. So thinking in these terms, it is easy to handle the symmetric tip rather than the other splits and other things. And also when it comes to repositioning and
please keep your question short. We are short of time.
It's my view of on different types of tips. I don't want to pose anything question, Dr. Tushar. So my views I was telling. So if we are doing reposition or fibrin sheath removal, so when symmetric tip is there, only one guide wire we can put it and do the procedures easily. When it's a split tip, it is difficult to do the procedures. So what's your comment on that?
Well, as I showed, I mean, there's no difference with the split tip or with the symmetric tip when it comes to recirculation in a reverse configuration. So again, it's the comfort at which you can place the catheter is an important point. As far as exchanging the catheter, even with a split tip catheter, you really need just one wire. You don't need two wires. So a catheter exchange, again, it's a comfort level. You don't necessarily need two wires to change a split tip catheter. You can do it with one wire, as same way as you do symmetric tip catheter.
Okay, thank you, sir.